Okay, so welcome everybody to our Friday conference here for the CFAR Clinical Core. I did just want to say, for those of you who were able to attend last week, thank you for being here. And I heard from Katie Godfrey after, who gave us her talk about Uganda. She just felt she was having a real feeling of support from the Hopkins community and just really appreciated being in the forum. So thanks to all of you who are able to join that. So today, just for a couple notes about upcoming schedule. So next week, I'm going to give a very brief introduction to how broadly neutralizing antibodies are being deployed in the HIV space, both prevention, curative therapeutic options, and what will be available therapeutically. And then Anna Durbin is going to spend most of the time talking about a broadly neutralizing antibody study that she, together with Joyce and others, are rolling out here at Hopkins. So please join us for that. And then the following week, we will have just a brief study announcement about the HOT study, which is about menopause. And then do some cases before we go on our August break. So hopefully we will see many of you there. And if anyone has a case they want discussed at that, please send them along. We do have a couple to talk about, but there's always room for more, and especially ones that people feel urgent about. So with that, welcome everybody. And today we are really fortunate to have Dr. Joyce Jones and Dr. Laura Beres joining us to talk about shared decision-making in HIV care. And I will turn it over to them.
Great. Thank you so much, Eileen. And thank you, Laura Clark and Christina Bunch, for giving us this time to present on shared decision-making in HIV care. This is a project that Dr. Beres from the School of Public Health, David Griffith, and I are working on with a medical education company called Medical Logics. And Cesar Pontes, who's a senior research program coordinator, she's also working on this project with us. She really contributed a lot to these slides and to the content of this. Next slide. So we received an unrestricted educational grant from Merck to work on this shared decision-making project. So Merck has not reviewed these slides. They did not make the slides, but they are sponsoring the project, including salary support for Laura, David, Cesar, and myself. Next slide. So our learning objectives today are really to define what is shared decision-making. I think we all feel that we do shared decision-making. We do shared decision-making, but having a common understanding of the elements of shared decision-making is one of our objectives today. How we might incorporate shared decision-making into our clinical practice. Specifically around antiretroviral selection and primary cardiovascular disease risk reduction interventions. So we're going to be doing some brief overview about shared decision-making. Actually, maybe next slide, Laura, I think we have an outline. So we're going to be talking really about what this project is about, why we're here, and then this is going to be very interactive. So we're looking to create a tool in Epic that will help support us to engage in shared decision-making with our patients. And we've chosen the areas of antiretroviral medication selection and primary cardiovascular disease risk reduction. So we're going to be again, going over the concepts of what does shared decision-making mean to you, talk about currently how we incorporate shared decision-making into our workflows and use Epic to help support that, go over models of shared decision-making, go over how these models might be applied in ART and CVD decision-making, risk reduction decision-making, look at some draft tools that we're thinking about that might be helpful in Epic, and then we'll do a wrap up. So this is a project that, again, this is the first sort of provider feedback piece. We're also talking to patients, and then we'll come back to providers again to get feedback, patients again, once we have something a little bit more fleshed out, so that we have something that hopefully will be really usable and helpful in our practice. Next slide. Go ahead. Okay, so why is it that we need to do shared decision making? So we know that people that we care for in Bartlett, and this is going to be in Bartlett and the county program, are older, and a large percentage of our patients, the majority of our patients, have chronic conditions. And about 1 in 3 people with HIV report that providers have not sought their input into their treatment plans. So really important that we have conversations about in these areas and we elicit participation and collaboration with our patients. Next slide. So I think I've already gone through this with you. So we're co-developing shared decision-making tools for HIV care focused on ART selection and primary prevention of cardiovascular disease. We want to create some tools that would be integrated into Epic. And then we'll also be having a CME session about these topics along with the shared decision-making tools that we end up developing. So this is like the first step in developing the shared decision-making tools. Next slide. And I'll pass it to Laura now.
Thanks, Joyce. And it's great to be here with everyone. Thank you for your time today and talking about shared decision making. So we're going to start with the interactive component. We're hoping that you all have a smartphone next to you and that you could please scan this QR code or even on your computer, if you want to navigate away from Zoom, you could put the link into the chat. But we're going to ask you what shared decision making means to you in just 1 or 2 words. And those should be coming up here. Oops. I'm so sorry. There we go. Now they're starting to come through. So we'll give everyone just a minute to do this. You also have the ability to like other people's choices. That's the good way to share your thoughts today. Right, so we have just over half of folks responding. So helping a patient choose, collaboration, active listening, priority setting, discussion, education. Another thought about priorities, sharing information, and doing things together. Great. So everyone else is welcome to keep responding, or we can always come back if there are other responses that get shared, but thank you. So then the next, helping the options and consequences. That's another one. Great. So if you could move to the next question, or again, if you need to reopen it and scan. We'd be grateful for you to share what are examples of decisions that you make within a routine clinical review with a patient living with HIV. So we talked about setting priorities, collaboration, options and consequences, sharing information and data. What, those specifically, are the decisions that you might share? What are some examples? And we'll give this maybe 5 minutes or so, depending on how fast things come up. There's a theme around the choice of ART, and in some cases, especially when there's drug resistance, initiation of statins, cancer screening, vaccine recommendations, whether or not to prescribe opioids, more generally, potential medical interventions, screening tests, changing regimen. So definitely some consistent ones there. Will you see a psychiatrist? So referral to other services and providers. Great. Those are helpful, concrete decisions to think about when we think about the application of shared decision making. So this is the last interactive question. And oh, actually, I just lied. There's saying that voting is in progress. Okay. Here we go. So this is the last question. So do you currently, yes or no, incorporate shared decision making into your interactions with patients living with HIV? Just quick response, yes or no. Great. And we've had about 8 responding throughout, so I think that may be what we have. So we don't have a problem of whether we do incorporate shared decision making, which is great. Hopefully the tools can support how we do it and how easy it is for folks to do it. So I'm going to go back to our PowerPoint. And you may not have known today, but we're actually going to ask you to come off of mute. Or if you really have to, you could use the chat. Although I know plenty of folks here are good at sharing thoughts. So if you currently incorporate it, which 8 of you said that you do, um, be really would love to hear an example of, a time that you've done it recently. How did you do it? Did you use tools? Was it a long conversation, a short conversation? Was it in a routine review in a clinical setting? Was it actually outside of that specific review? And how did it go? So if there are 1 or 2 folks who would be willing to share an example, we would be grateful.
All right, I'll go first.
Thank you, Eileen.
I'll be quick. So I recently had a new patient who was on elbitectivir cobicistat and was going to get some upcoming analgesic and steroid injections. So there's an interaction there. She had discussed multiple times before with other providers and really wanted to stay on her regimen. So I tried to have another discussion about it with her and just asked her why she wanted to stay, told her a bit about why I thought there might be an easier alternative, um, asked her what questions she had, and then ultimately what she wanted to do was text her original HIV provider from like 15 years ago. And I encouraged her to do that and then to message me after that. So that was one example.
Thank you. And did she message you?
She did, and she changed.
Great. Yeah. Fantastic. So framing the decision, talking about alternatives, asking about questions, and then coming to a conclusion.
And then I think Matthew was politely raising his hand.
Wonderful. Thank you. I couldn't see that. Please may you share, Matthew.
Yeah, I I, I was thinking about a patient who was fatigued with oral antiretroviral therapy who was very keen to transition to long-acting injectable therapy who had a an NRTI mutation that wouldn't preclude the use of injectable treatment, but had a long history of less than perfect adherence. And so there was a concern about other mutations being archived that might compromise an injectable regimen. So it was just having a conversation that sort of communicated the uh, the risk and the potential for the long-acting injectable to be to not be effective. The patient was happy to take that to take that risk, if you like, and continue with injectable treatment. And it's particularly hard when you don't have a quantifiable way of saying this is it. You have a 10% chance of having an archived mutation that may be relevant.
Thank you. A helpful example in communicating uncertainty.
I was going to say that I see patients over in oncology who have HIV and some type of cancer, and I'm regularly discussing whether they want to go on a treatment trial or go with the standard of care, and discussing pros and cons of both of those things and then helping them make that decision.
Another great example. Thank you.
I have had a discussion with a patient. Oh, sorry for the background. I should have changed that. But patient who was engaging in risky sexual behavior, um, but primarily thought their perception was oral sex was pretty much benign, and introducing the discussion on doxypep and whether they had heard about it and their thoughts, but trying to get them to understand that they were in a situation where they still could contract an STI, even though they felt that they've already been exposed to all there is, and therefore it did not matter anyway. So trying to have that discussion to encourage them to consider prevention, this prevention strategy.
Thank you. So reflecting on behaviors and potential interventions to support or mitigate risk. Thank you so much to everyone for sharing. Anyone else?
I I think frequently end up having a conversation with people about the switch to long-acting injectable, similar to what Matthew was saying, but usually the conversation we have is ends up around like the 1% failure rate. So it is a little bit different in that I can give them like a quantifiable number. And for some people, they're okay with that, and some people are not okay with that. So I think that's a really helpful piece to talk about, because some, people have different levels of comfort with different types of risk.
Absolutely. Absolutely. An increasingly common conversation. Great. Well, thank you so much for those examples. We're trying to think about tools that might be helpful. It's helpful to think about real applications, potential applications. So the next thing that we had hoped to do and appreciate your help with is to think about how you use Epic in a routine encounter. So what a workflow would look like when a client comes in. So I don't know why that's red. Sorry, slightly less challenging color. If And obviously Joyce and David have many examples of workflows, but the when a client comes in for a routine encounter, what are the Epic tools that you use while they're in the room? What's the first one that you open?
And Laura, are you asking specifically around like with the shared decision making, right? There's like a something, a topic, or is that what you're wanting to query more about at this point?
Potentially, if there are tools that you're using for shared decision making, but I think
Mhm.
also it's to relate how new tools might integrate or not
Mhm. Mhm.
into the
Mhm.
workflow of speaking with a patient. So you open up by greeting them and, asking about concerns.
Yeah.
Where
How
is
do you start
there
your visit?
value
Sure.
in engaging with Epic, and when is it, frankly, just kind of in the way? Especially as you're thinking about conversations with patients, right? Shared decision making involves conversation. So are there examples of conversations where you're using Epic tools currently?
So I'll just say, like, if I'm discussing like a particular trajectory in viral load or weight, I will often turn the screen to the patient and say, this is what I'm concerned about, or, you know, yes, every time you come in, we talk about how your blood pressure is going to be better next time, but let's actually look back through and you're doing all these great things. It's still not working. Maybe it's time to think about medicine. So I'll use it in that way. But I don't know, in my workflow, I usually I don't type very much while I'm talking to the patient.
Mhm.
Um, and I try to do the things I need to do. Like at some point, I usually talk to the patient first, and then I will turn back and be like, okay, let me just go over the medication list. Let me just make sure this is updated. But my notes are always delinquent. So.
No, they're not. I know that they're not. So, do you use a tool to show the viral load trajectory, blood pressure, weight? Are there any tools that you use in Epic?
So I in my notes will often just like I'll do like last weight 3, last blood pressure 3, so I could just have a little quick chart. And then in every patient who's mine, I manually input their CD4 count and viral load over all the years that the data is available. So I'll just scroll down to that part and I'll be like, oh, if you look back here, you're having trouble, but that's all just manually done. It's not an Epic tool because I'm a Luddite.
But it works as a fellow Luddite. Others, tools that you use that help with patient conversations.
I know some people do really integrate their work in Epic with patients. So if anybody can say how they do that, it'd be great.
Yeah, if someone's willing to share that magic with me as well, I'd be thrilled. I'm delinquent like Eileen and can't multitask and make eye contact and type at the same time. But one of the things that I've started to do recently is when I'm doing the after visit summary, I'll turn the screen so that the patient is like reading it as I type in the sort of the key points, and then I'll ask them to read it and say, did I miss anything there? That's about as sophisticated as my use of Epic is, but I think it helps with some of these decisions.
Yeah, and certainly a way to engage the client in their record, right? Which is something we've had come up frequently in patient conversations of these are my data, and do they represent me in a way that is consistent with what I think. Gail, thank you.
I'll just say that I do use a bridge very frequently, almost in all my visits. And I think there's ways you can use it, even if you don't want to use it for your main note. You can use it to write the after visit summary in seconds. So if you're in that after visit instructions field, if you have made a bridge recording, you can just type a dot phrase. I can put it in the chat, and it will come up with a layman's summary of your visit with instructions, which is usually much more comprehensive than anything I can type quick enough.
That's really helpful. Thank you for sharing that dot phrase as well. A bridge. Thanks, Joyce. Typos. Anyone else? Okay. Joyce, any other questions for this one, or?
I think we can query a little bit more, in the future slides.
Yeah.
Other Epic
No,
tools.
this is really helpful, and thank you for that. Okay. So we talked about tools and modules, tools. So
Your whiteboard
are
is
there
showing in the back.
are there tools that you specifically use around cardiovascular health? As we think about that as one of the targets, cardiovascular disease.
There is the dot phrase dot ASCVD risk in Epic, although the calculator that it uses I think is kind of outdated, so I've kind of stopped using it and have to just kind of manually calculate. Although now that the AHA made that new recommendation, I don't use that as much as I just go right into talking about how it's recommended for everybody. But yeah, that was one of the main ones I used to use and then started just kind of calculating it on my own.
That's really helpful. So unfortunately, a little bit outdated. Gail's saying the Mayo Lipid Decision Aid. Appreciate using the chat too if there's anything else.
How are you all incorporating Reprieve? Like, are you doing that, the Reprieve data? And are there any resources that you might use for that discussion?
So I, similar to Emily, used to use the ASCVD risk calculator when there was like a graded recommendation from Reprieve, but with the new ACC/AHA guidelines, it's pretty much if you're 40 and have HIV, then so that similar to Emily, it kind of moved towards more universal recommendation. It is sometimes so helpful to just say to the patient, like, this is like a risk number, but again, that, individual risk perception is quite challenging, I think. Like, what does a 5% chance mean?
Yeah.
But Gail might have more. Yeah, Gail is saying super important things in the chat, so she should.
Yeah, so the nice thing about the Mayo Decision Aid is it's one of those ones that shows you like 100 people's, and then it shows you, what percent of people with your characteristics would be expected to have a heart attack over the next 10 years. But it is not for, HIV is not something you can select to like incorporate into it. But I think some people do like those visual representations, and it can be effective. And then you can show if you put you on medicine, how that shifts in terms of the 100 people that it shows. And then if you're used to using the ASCVD calculator and you're in an under 40-year-old, the PREVENT calculator would be one that you can use now for those people you're kind of not quite aged into Reprieve.
Thank you. And then any tools that anyone is specifically using now around ARV selection or regimen switch? Larry just put in the chat a guideline statement and PREVENT calculator. Thank you. HIV assist. Any other thoughts on ART selection? Okay.
Occasionally, we'll look at Liverpool, like the drug interaction, just to show people what is happening there.
Great, thank you. So again, really appreciate the feedback and the thoughts and understanding a little bit more about what some of the tools are that are being used. We're going to transition now into just looking at two models that were developed to support decision making, and many of you probably know them already. And I think that certainly the examples that were shared cover these topics. So the Agency for Healthcare Research and Quality has their SHARE approach, which is a framework to help think about what are the components of shared decision making. So as you can see, S being for seeking your patient's participation. So inviting them to actually take part in the decision, signaling to them, letting them know that there is a role for them if they wish to have it, and that this is something a way that they can engage. Helping the patient to explore and compare the treatment options. That's something that was talked about, options and consequences. Assessing the patient's values and preferences. So just like many different patients have different perceptions of risk, different tolerances for risk. What is important to the patient? What are some of the criteria, either explicit or implicit, that they may apply when making their decision? Then reaching the decision with the patient and evaluating the patient's decision and how it's working. So some of this can happen in a micro way in real time, and then some of it is, in a follow-up phase. There's another commonly cited model, the 3-talk model. and it's different kinds of conversations. So the first being team talk, establishing again that a decision needs to be made. So this is parallel with seek, right? So creating a situation where the client feels safe, where they understand that it's their right to be involved, that their engagement is normal and not, exceptional for any of the decisions that you might be moving to discuss. And then option talk. So again, helping the H from the share model, helping the client to understand the options, discussing the risks, the benefits, and what some of the different choices may mean for them. And then the decision. So exploring here again, we have the share model, patient's preferences, and assessing values and priorities, coming to an actual decision, and then understanding what's important for that client, not only in the decision that they made, but thinking about that evaluation phase of share. How would this decision be a good decision or not a good decision for them? So two very similar processes framed differently, but that each of these phases is important in creating an environment and a interaction where the decision making is shared, and not just that decision, but evaluating its outcomes. And so again, you've described applying this in your own clinical practice. We do know that, not within JHU, but in the larger community, as Joyce said, there are many clients who don't feel that they have been engaged in a shared decision-making situation in their HIV care, and that we do have tools in Epic which may or may not be helpful. So trying to think about what could be. There are some things that this project will not be able to do, but things that are potentially in scope are smart sets, dot phrases or smart phrases, visit checklists, option grids, patient education tools to support the patient to be in a position where they feel better able to engage, either in communicating with a provider or in specific information about cardiovascular disease, about ART, for example, best practice advisories, care gaps, synopsis, and we're keen to hear from you if there are potentially other options you can think of that might be helpful. So Joyce, I'll turn it back over to you, I think. Not quite yet. Okay. So these we've covered in the last discussions. And I think Joyce is struggling to unmute, unfortunately. Can someone?
Okay, sorry. It went into like a drawing tool and I had like a pencil I couldn't I couldn't remove. So I'm gonna go through now what so David and I sort of brainstorming along with the Epic folks, looking at examples in the literature of how shared decision making has been incorporated into clinical practice. I'm going to give some examples and want to hear from you all what you think in terms of would these be helpful? Obviously, would it be helpful? Don't want to just create something that nobody uses or that's annoying, right? So next slide, Laura. Okay, so when we're thinking about different tool types, and just sort of conceptualizing what's needed in shared decision making, we thought that having something that helps us make sure that we're including all of those important steps in shared decision making, that we're doing all of those things, right? Sometimes it can be easy to just kind of present information without necessarily fully eliciting the patient input, what are their values, what are their priorities in making the decisions. So operationalizing the shared decision-making framework. So potentially having some type of a checklist regarding the steps for ART selection or primary cardiovascular disease prevention that includes all of those shared decision-making steps. Having a dot phrase that outlines those steps that are being used, and then an option grid. So let me, next slide. So this is an example from the literature of a group at Mass General Brigham that when making shared decision-making about an approach for orthopedic surgery, they made a dot phrase, right, that goes through sort of engaging, I engage this patient in shared decision-making conversation to determine the best approach to manage the patient's hip osteoarthritis, right? And then they can sort of choose. There's some places where you're putting in what were both the patient's clinical situation and then what were the options that were discussed. So having some type of a dot phrase that again helps kind of walk through all of the kind of critical steps that we think should be included when we're talking about ART selection, when we're talking about primary cardiovascular disease prevention. So that's one example of something that could help us operationalize shared decision-making in these areas. Next slide. This is an example of an option grid that one group included in the into the EMR, where it goes through what are the different options for, in this case, it was treating uterine fibroids. So there's an option to watch and wait. There's an option to do medicine with hormones, medicine without hormones, or embolization. And then what does the rows are, what does the option involve? And then different questions that a patient might have, along with some data that goes through each of those different options. So having sort of an option grid going through each of the different choices, that's another tool that's been used in other settings to help support shared decision-making, in this case around uterine fibroid treatment. Next slide. So then there's sort of what we might include content-wise and how we might include it. And then again, thinking about, so when we're engaging in shared decision-making, we both need to know the patient in front of us, right? And what are their values? What's their input? And then we need to have the tools so that we can present the best evidence, right? So also thinking about in a shared decision-making tool, what might be some external tools that would help us lay out for the patient the pros and cons of each decision. And in some cases, they can act as a tool to educate the patient and to engage in the conversation. So some of these were already brought up: HIV Assist, the Stanford database, right, to help us really think about what are viable options in terms of ART selection, the Liverpool Drug Interaction Checker. I think, is this what you use, Gail, the Mayo Clinic CV Prevention Decision Aid?
Yeah.
Yeah, it's really nice, and I'll show you that is something that's been published as well, where you can input patients' clinical data, and then you can toggle, like if they're smoking or they're not smoking, how that changes their risk. If they're on a statin or not a statin, it does not include the reprieve information, but again, there are other things beyond a statin that can mitigate risk. And so having something visual to show patients can make things be better understood about the risks and benefits of different options. in my practice, when I talk about reprieve, for many patients, it's information to them that their individual risk of cardiovascular disease is increased by having HIV in and of itself. And I will show them, there's some graphics that will just sort of show the patient about decreasing their cardiovascular disease risk, what was shown in reprieve, because people don't necessarily want to take additional medications, right? So that can be helpful as well. And then other things that could be pulled in, to help both with your documentation and with the what are the risks, benefits for an individual patient, are the relevant patient-specific data. So, having at hand last CD4, last viral load, their current medication list, their allergy list, and we talked about the limitations of the current CVD calculated risk, but potentially there could be a different calculator that we could put together that could automatically be put into a note. Next slide. So I'm not going to go into detail of this, but this, and we'll send out these slides. I don't know if somebody can put the link to this in the chat, but this is a really great kind of interactive risk calculator. Again, you put in the patient data, you put in different characteristics, smoker, non-smoker, Mediterranean diet, not Mediterranean diet, exercise, not exercise, and it visually shows the 10-year risk, current risk, future risk. Next slide. And this group, they actually embedded this risk calculator into Epic. So it automatically pulled in the demographics and the labs. So it was like an embedded tool in Epic. Next slide. And then also just patient education. I think that in my experience, obviously, and I think in our own experience, the more that we ourselves sort of understand, the more we will be to engage in whatever is the new intervention, right? So also making sure that within whatever tool we have some embedded links or resources for patients that they can go home with or they can look at with you. And that's where in this project, we're going to be eliciting feedback from patients about what they think might be helpful. And then this is a tool that was created for gay and bisexual men in navigating HIV care. And it was specifically created for the patients themselves. Next slide. So different things that we could do. We can create a smart phrase. So that's the dot phrase that just automatically kind of lays out, a template and information, and it can embed different data into patient-specific data into that text. Smart sets can be very powerful, and I'll show you a little bit example if you don't have a lot of experience with smart sets. And then using care gaps where potentially, and this would be a proposal, there could be a gap that we create where we say, once a year, I want to make sure I talk about primary cardiovascular disease prevention with my patient, right? So the gap shows, and then if I do a smart phrase or do the smart set that helps me engage in shared decision-making with my patient, that gap is filled. So something to consider to help support us in reviewing these things with our patients. Next slide. So this is an example of a smart phrase that was incorporated into an HIV clinic to help, again, support shared decision-making and best practices around HIV care. We do some of this already with some of our templated notes. So there's a potential to do something similar like this that we could all share when it comes to ART selection and/or primary cardiovascular disease prevention. Next slide. This is an example of a smart set. So this exists in our Epic right now. There's a prep smart set that I'm just going to show you a little bit of an example in case you're not familiar with smart sets. So smart sets are a particular section in Epic. If you choose that smart set, if I choose a prep smart set, next slide. It embeds, so this smart set has at the ready a templated note. So rather than having to do a dot phrase, I know that I'm going to either have a new prep or a prep follow-up with a patient, right? There's a templated note in there already that I can choose and I can edit. It has embedded in it diagnosis codes that are relevant to the topic at hand. It has embedded all of the lab tests that one might choose for that prep visit. And this smart set has oral prep, it has injectable prep. There are all different sort of sets of labs available to choose. Next slide. It has medications that are commonly prescribed. It has after visit summary that can be embedded. And then when should they follow up with me? So it really bundles together all that might be needed for a particular type of encounter with a patient. Next slide. And then we know about care gaps, right? So so we have the primary care gaps that exist, and then Randy Borman and I have been working on developing the HIV specific primary care gaps. And so again, potentially there could be one for reviewing primary cardiovascular disease prevention. For the ART selection, I'd be interested to hear what you all think about making that a gap. Like, should we review once a year how people are feeling about their ART choices? Should be, helping make sure that we're reviewing what are new things that may be coming down the pike, things like that. Next slide. So that's it. So I know we only have a few minutes left, but interested to hear people's reactions to this project. All of the feedback is welcome. That's the whole point of this presentation and this project, is trying to create something that could be useful, again, to help support us and patients to engage in shared decision-making. And we chose ART selection and primary cardiovascular disease prevention as the two areas.
Thank you so much, Joyce and Laura. Gail, why don't you go first, and then I have a question too.
Oh, I was just thinking, as you were saying, I've seen some patient-facing tools like checklists for the patient to indicate the things they want to discuss with their doctor, and I wonder if that's a good way to engage the patients in this process as well. And then I would say I looked at this a while ago for patients with multiple sclerosis, and they've done a lot of work around some of the options. And instead of in addition to option grids, they would have really short patient scenarios, sort of that kind of ran the span of I want every aggressive therapy I can, no matter what the side effects, to I really don't want to experience any side effects, give me the minimal, but they were nice little brief stories, and the patient could pick which one they were most aligned with. And some people like that story aspect of it. So.
Those are great suggestions. Thank you.
One thing that struck me as in going through this was it seemed like some of this seems to fall into the category of providing information so that the patient will agree with a recommendation that we know to be protective, which feels different to me than shared decision making, but from the tool-based perspective, we know that the current recommendations are that every person with HIV over 40 should be on a statin. And so some of the things we're marshaling to support that are like pictures that might make you agree with that or disagree with that. So I just wondered a little bit about the thinking around that, because like I think with ART choice, there's a little bit more where it feels like, okay, pick your poison, which is slightly different than, or choose your risk, right? Like what level of risk do you want to have, or what bothers you the most, taking a pill every day or getting an injection with a 1% risk of failure. I tend to have this like slightly nihilistic view of like, we don't as humans understand what a 10% chance of rain is. So like, we don't understand what a 1% failure rate is, but people do have a gut response to that can guide their actions. But like from the cardiovascular perspective, I think some of it, like it's like a colonoscopy. Like we can have shared decision making about it, but basically you're going to either agree with my recommendation or not, right? Like I mean, like should you be screened for colon cancer? Yes. Like I mean, not for everybody. Like if you're 80 and whatever, but like I mean, in general, then it's like where's the line between sort of convincing someone or providing them like education versus actually saying, yes, you can choose to not take medication. You can choose. Do you know what am I making any sense?
Yeah, and I think that with the shared decision making, it involves hearing more from patients about like what their values are and understanding, and so much is trust is building of trust, right? And so by creating space, there are some people who just will say yes to, whatever you might recommend, but again, with this sort of, and with colon cancer screening, there are options, right?
No, totally.
Right.
Just to clarify one thing, I think like
Okay.
it's sort of bumping up for me against the like documentation requirements, right? Like in terms of like, I get yelled at. Like someone came up for colon cancer screening the other day that was ordered. He's in active therapy for CNS lymphoma. I'm going to ignore that care gap and defer it, right? Like, there's like, but the idea being like, do I need a smart set or do I need to just have a conversation? If the patient still doesn't want to take antihypertensive, then like I don't know how to think about what is the role of the documentation piece and this information presentation and then also those conversations. Again, I may not be making any sense.
Yeah, no, and I guess that through the tools, it helps ensure there's sort of a standardized set of information and things that would be helpful for people to go through when they're having conversations with patients about the topic at hand. So we have we have a framework of what would be a good approach. And then obviously each patient is going to be different in terms of their values. So just wanting to have something available that could be helpful, across the board for all of us.
And I guess I'll just say that I think Tracy's comment that a smart set feels good for that feels like as opposed to a like repeated prompt for something, but like when you're going to engage in that type of a conversation and go through all the data that there's a tool available feels to me, but I don't know, Gail, you're much better at using Epic than me. I don't know what you think in terms of care gap versus.
I think the hard part is you're actually not allowed to refuse any, like if a patient decides they're not going to get their colon cancer screening, they're not, HEDIS does not allow that as a reason for not counting that in your denominator. So the only thing you're allowed to actually refuse on all the HEDIS metrics is your flu shot, and that's the only one. I see the tension between like, we want to close these care gaps with like, we want to do shared decision making, where patients may disagree that they don't want to do whatever we would need. So I think it's just a tension between those two things. But I think if building in some things to prompt that discussion, but then giving physicians ways or patients ways to make those discussions patient-centered is probably helpful.
What's your sense about a smart set, Gail, or sort of tool that might be useful?
Yeah, I'm trying to think. Like I do think like diabetes has all of its care gaps in the like diabetes has 6 things that go into that care gap panel, and HIV has none, right? So I do see a role where it could support just decision, like awareness there, and then obviously you're going to have a conversation with your patient. Um, I think in terms of more complex decisions like antiretrovirals, like I have patients who come to me and every year they say to me, what's new? What should I be looking for? And then I have patients who come to me and they never ask that question. So I do think it's some kind of prompt, but whether it should be on the patient side or physician side, like to sort of reevaluate, the antiretroviral regimen, maybe once a year. But I also don't want to overburden people knowing that we still have those 5 diabetes gaps to get through too, plus creating our own gaps. So
Great. Well, I see we're over time. So thank you so much. Please give feedback. Please email me, David, Laura. Would love to hear what you all think. And we'll be back to present something a little bit more formulated using what we heard today. So
Thank you so
Yeah.
much for
And certainly recognize the risk of making things harder and then actually
yeah,
reducing the shared decision making. So that's
yes.
what we're trying to avoid. Sorry, Eileen. Thanks.
No. I wanted to say thank you so much. We talk about this all the time, but like the actual mechanics of it, what you need on the provider side, what the patient like are often skimmed over, and to have this kind of like really clear framework for approaching this is super helpful. So thank you for this work and thank you for coming today.
Thank you so much. Have a nice weekend.
Take care, everyone.
Bye.